we know, AKA occurs in 5.7 to 24% of ICU patients and is commonly associated with multi-organ failure, sepsis, renal hypoperfusion and pre-existing renal disease. Renal replacement therapy is reportedly used in 51 to 82% of patients in AKA in ICU patients. An estimated 2 million people worldwide die of AKA every year, whereas AKA survivors are at increased risk of developing chronic kidney disease and end-stage renal disease. The primary objective of this study is to examine the clinical characteristics and outcomes of patients with severe AKA in a tertiary care hospital, and especially focusing on the conversion to AKD and CKD and ASRD. Aims and objectives of the study. The aim of the study is to assess the long-term outcomes in patients of severe acute kidney injury. The objectives are to describe the clinical characteristics of patients of severe AKA, to determine the outcomes of severe AKA, to assess the prevalence of acute kidney disease and chronic kidney disease in patients of AKA. Coming to patients and methods, this is a retrospective record-based study which was conducted in a tertiary care public sector hospital, and the case records of patients with severe AKA admitted during the study period from January 2016 to January 2020, that is 4 years, is taken. Inclusion criteria of the study included patients aged more than 18 years, patients with AKA stage 3 admitted during the study period, and case records availability. The exclusion criteria are patients with established diagnosis of CKD are excluded from the study, and the case records unavailability, and AKA stage 1 and 2 are excluded from the study. Coming to methodology, the study is a retrospective design conducted in a public sector hospital, and all the details of the patient of severe AKA requiring RRT are obtained from the case records during the study period, and they are followed up till January 2023. And patient demographics, clinical characteristics, etiology, renal replacement, vasopressor use, mechanical ventilation were recorded, and biochemical and hematological parameters at the onset of RRT were noted. And patients were further followed up with a renal function test, urinary protein, and ultrasound abdomen. And the two modes of RRT, hemodialysis and peritoneal dialysis were done, and primary outcomes assessed were mortality, complete recovery, progression to acute kidney injury. And the survived patients were followed up for a median duration of 18 months, and the outcomes assessed were recovery, mortality, progression to CKD and ESRD. This was the study design of the patients. The total patients studied in our study was 815, which we assigned as group 1, and these patients were followed up for mortality and complete recovery and AKD. In these patients, the survived patients, which includes the group 2, that is 515 patients, were further followed up for outcomes like recovery, CKD, progression to ESRD and death. Coming to the results, these were the baseline characteristics of the study population. The mean age of the population was 45 years, and the males accounts for 57% and females accounts for 42% of the patients. Diabetes is seen in 17% of the patients, and hypertension is seen in 26% of the patients. Oliguria and breathlessness were the most common clinical features in our study. Coming to the etiology of AKA in our study, sepsis accounts for the most common cause of AKA in our study, which accounts for 41.7% of the causes, and cardiac causes accounts for 19.5% of cause, and tropical AKA accounts for 20% of the cases, and poisoning accounts for 8.5%, and trachea and obstructive causes accounts for 6%, and hepatic related causes accounts for 2.9%, and others accounts for 2.5%. This was the figure showing etiology of AKA in our study. And this is a table showing lab parameters in our study. The mean HB in our study was 9, and mean serum creatinine on admission was 6.4 mg per dl. And these were the other lab parameters in our study. Coming to the distribution of outcomes in the group 1, that is the total study population, and the group 2, which were the survived patients. In group 1, that is total of 815 patients, around 48% of patients progressed to AKD, and 15% of patients underwent recovery, and 36% of patients had mortality. In group 2, that is the survived patients which were further followed up, the recovery was seen in 61% of patients, and progression to CKD was seen in 28.7%, and mortality was seen in 9.3% of patients. This was a figure showing outcomes of AKA in the total study population in our study, and this was the outcomes of survived patients as we have discussed it. This is a table showing Q-SOFA scores in our study, where 50% of patients have a Q-SOFA score of 1, and 33% has a Q-SOFA score of 2, and 13% has a Q-SOFA score of 3. And the mode of RRT in our study, that is 63% of patients underwent hemodialysis and 36% of the patients underwent peritoneal dialysis. The need for inotrope support was seen in 31% of patients, and need for mechanical ventilation was seen in 21% of patients. Coming to the table of factors affecting AKA recovery and progression to AKD, in patients, elderly patients had recovered before day 7 when compared to patients who have progressed to AKD, and patients with breathlessness and oliguria have progressed to AKD when compared to patients who have recovered before day 7. And patients with elevated LFT have progressed to AKD when compared to patients who have recovered before day 7. And there was no significant correlation between Q-SOFA scores, mode of RRT, inotrope support and mechanical ventilation in patients between these two groups. Distribution of comorbidities between these patients who have recovered before day 7 and AKA patients who have progressed to AKD, there was the diabetes, hypertension and coronary artery disease was have higher incidence of patients have higher incidence of diabetes, hypertension and coronary artery disease in patients progressed to AKD when compared to patients with AKA. And distribution of etiologies in patients patients who have recovered before day 7 and patients who have progressed to AKD. The incidence of in obstructive uropathy, hepatic causes and poisoning, there was higher incidence of patients who have progressed to AKD when compared to patients who have recovered before the day 7. This was the graph showing distribution of etiologies of our study. Coming to multivariate regression analysis of AKA recovery and AKA progress to AKD in our study. None of the parameters did not show any association between the two groups. Coming to mortality, distribution of mortality in the patients in various etiologies. Sepsis accounts for the most common cause of mortality in our study, which accounts for 43% of the patients, followed by cardiac causes, which is 20% of patients, 20% of causes. This is a multivariate analysis of characteristics and association with mortality in patients with in our study. These parameters, patients with thrombocytopenia, patients with elevated LFT shows a higher had higher incidence of mortality in our study. But on multivariate analysis, there was no significant association between the parameters. And patients with higher Q-SOFA scores and patients on peritoneal dialysis, patients on mechanical ventilation have higher mortality when compared to patients, survived patients. Coming to the table of long-term follow-up of patients with acute kidney injury. In the survived patients, 9.3% of patients underwent had mortality, and the survived 467 patients, that accounts for the 90% of patients. Recovery was seen in 61.9%, and progression to CKD is seen in 27.7%. Stage 3A, CKD stage 3A accounts for 4.6%, and stage 3B accounts for 4%, and stage 4 is seen in 11% of patients, and stage 5 is seen in 8.9%, and progression to ESRD is seen in 6.7%. Proteinuria is seen in 15.9%, and hypertension is seen in 14.4% of patients. Coming to the characteristics of patients with recovery and progression of CKD, recovery is seen in 319 patients, which were compared with the progression to CKD, that is 148 patients. When there was patients with the coronary artery disease have progressed to CKD when compared to patients who were recovered, and patients who are non-oliguric were progressed to CKD when compared to patients with who were recovered. And coming to the lab parameters, patients who have higher WBC counts and patients who have thrombocytopenia have recovered when compared to patients who have progressed to CKD. And there was no significant association between the Q-SOFA scores and mode of dialysis, inotrope support and mechanical ventilation between the two groups. And multivariate analysis of the patients between these two groups shows patients of coronary artery disease have 1.97 times more associated with progression to CKD when compared to patients who were recovered. Coming to the discussion, As we know, the definitions of AKA depends upon the AKA, AKD and CKD depends upon the duration and functional and structural criteria. Duration of AKA is within 7 days, whereas in AKD within less than 3 months, and CKD more than 3 months. And this is the AKA CKD conundrum, where the AKA patients can have various outcomes like early recovery, late recovery, mortality, or progression to CKD. This is the table showing comparison of various studies of AKD progression, where study group, these are the various studies where which were done in different patients, like hospitalized patients, ECMO patients, liver disease patients, and ICU patients, and they were followed up for various durations. And the AKD phenotype was AKD after AKA or AKD versus no AKA. And in various studies, AKD after AKA was 53 in Geo et al. And Nagata et al. It was 66.8%, whereas in our study it was 48.2%. And mortality hazard ratio was 1.98 in other studies, whereas in our study it was 36.8%, and progression to CKD was 28.7% in our study. This was the comparison of various studies of CKD progression, where which was done in various clinical settings, and the follow-up periods. And mortality in various studies was around 20 to 40% in various studies, and in our study it was mortality was 9.3%, and ESRD rate was 6.79%, and progression to CKD was 28.7%. Coming to conclusions, sepsis was the most common etiology of AKA in our study, followed by tropical AKA and cardiac related causes. Out of 815 patients of AKA, 15 patients recovered, and 36.8% patients had mortality, and 48% had progressed to AKD. And younger age, presentation with breathlessness and oliguria, raised liver function test, and lower serum potassium were associated with progression to AKD in our study. And no significant association of underlying comorbidities with progression of AKD. And factors affecting mortality in our study were higher total serum bilirubin levels and higher QSOFA scores, patients on peritoneal dialysis, and need for mechanical ventilation. And out of 515 survived patients, 61% of patients had recovered, and 9.3% had mortality, and 28% of patients had progressed to CKD. Patients who progress to CKD has higher prevalence of coronary artery disease compared to recovered patients, with an odds ratio of 1.97. Thank you.